Usually when we talk about a medical diagnosis, there's this expectation of precision, like engineering.
Right, yeah, like a straightforward cause and effect.
Exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points to the screen and says, well, there it is.
The clinical picture is completely visible, it's categorized, and honestly, it's comforting. For both the clinician and the patient, you have a definitive answer.
But then you step into the world of perimenopause and women's health, and suddenly that x-ray machine is just broken.
Completely broken, yeah.
We are looking at a diagnostic landscape that is entirely murky. So today we are bringing you into a very specific, absolutely fascinating biological mystery. How does a doctor actually know if a woman has reached menopause when she is already on the contraceptive injection?
Which is such a massive question in clinical practice.
It really is. And to figure this out, we have doled together a massive stack of clinical guidelines for you. We're looking at the UK's Faculty of Sexual and Reproductive Healthcare, the FSRH, the Royal Australian College of General Practitioners, the North American Menopause Society, and just a whole host of medical FAQs.
And that represents a huge mountain of data. Yet every single one of those sources points to this one, incredible clinical dilemma. It completely flips how we normally assess the female body.
Because menopause is usually diagnosed by a beautifully simple metric,
Yeah.
right? 12 consecutive months without a period.
Right. That's the gold standard.
But what happens when your birth control already stops your periods? Okay, let's unpack this. Let's look at the actual drug at the center of this puzzle.
Right.
We're talking about Depo-Provera or depomedroxyprogesterone acetate.
Yeah, so this is a long-acting progestogen injection. Depending on the exact formulation, it's administered either into the muscle or just under the skin every 12 to 13 weeks. And what we see in the clinical data is that it doesn't just prevent pregnancy. It fundamentally alters the menstrual cycle. The sources actually note that more than 50% of women stop having periods entirely after just 1 year of use.
Wow. 50%.
Yeah, and it goes up to nearly 70% who achieve complete amenorrhea after 2 years.
Which is, often a massive benefit for the people using it. I mean, no periods.
Oh, absolutely. It's a huge selling point.
But if you are a clinician trying to diagnose menopause, you are essentially flying blind. It's like trying to figure out if your car battery is completely dead, but someone has permanently disconnected the headlights.
That is a great way to put it.
The most obvious signal, the lack of a period, is just gone. You can't rely on that traditional 12-month countdown.
What's fascinating here is that the baseline has been totally erased by the medication. A woman could be fully menopausal, or she could be highly fertile. And from the outside, the symptom profile, having no periods, looks completely identical. Historically, before these modern guidelines were established, this was largely just a guessing game.
Which sounds incredibly frustrating.
It was. A clinician might have suggested a patient just stop the injection and see if her period came back or, see if she started getting hot flashes.
But that's a terrible user experience. You're asking someone to risk an unwanted pregnancy or endure severe perimenopausal symptoms just to get a diagnostic answer.
Exactly. It's not practical or fair to the patient.
So if bleeding is a dead end and the historical wait-and-see method is a nightmare, what is a clinician supposed to do? They can't just guess.
No, they definitely can't. We have to look elsewhere.
And that brings us to the intersection of age and the side effects of this specific drug.
Right, because the urgency to look under the hood increases dramatically as a woman gets older. We start having to really weigh the benefits of the contraception against the physiological toll the drug takes over, decades of use.
And this stood out to me as a striking fact across all the sources we reviewed. UK, Australian, and North American guidelines uniformly advise that women should seriously reconsider using Depo-Provera at age 40.
Yes.
And they're generally advised to stop or switch to another contraceptive method by age 50.
That's the consensus, yeah.
I want to push back on this for a second, though. If this injection works so incredibly well, it's highly effective, it stops painful or heavy bleeding, it's super convenient just getting a shot every 3 months.
Sure.
Why the rush to get off it at 50? If a patient likes it, why not just let her take it until she's 55, when natural conception is exceptionally rare anyway?
Well, the clinical hesitation comes down to a concept called hypoestrogenism. Depo-Provera doesn't just suppress ovulation, it strongly suppresses the body's natural production of estrogen.
Okay, and estrogen is super important.
Oh, it's a multitasking hormone. One of its most critical jobs in the human body is protecting bone health. It essentially acts as a brake on the cells that break down bone tissue. So when Depo-Provera turns down the estrogen, that brake is lifted, leading to a temporary loss in bone mineral density, or BMD.
Oh, wow.
To put the sheer biological toll into perspective, the bone loss during the first 2 years of Depo-Provera use is roughly equivalent to the bone loss during 6 months of pregnancy and breastfeeding.
That is a massive amount of bone density to lose. So if we connect this to the bigger picture, think about what naturally happens to a woman's body around the age of 50.
Right, natural menopause.
Exactly. She is approaching natural menopause, and the hallmark of natural menopause is a steep, permanent drop in estrogen, which of course also causes a natural loss in bone density.
Yes, and clinicians want to avoid stacking those two effects. They are looking at a patient whose bones are already becoming vulnerable due to natural aging,
Right.
and they absolutely do not want the hypoestrogenic effect of the injection colliding with the hypoestrogenic reality of menopause. The compounding effect could really increase fracture risk.
That makes total sense. Though the guidelines explicitly state that bones generally recover once the injection is stopped, right? The density stabilizes and rebounds.
Yes, that's an important caveat. This isn't necessarily a permanent destruction of the skeleton.
But it's still a vulnerability that forces a decision. Because some women might choose to stay on it past 50 to manage severe endometriosis or just debilitating heavy menstrual bleeding.
Exactly. They decide the immediate quality of life outweighs the theoretical bone risks.
But for everyone else, figuring out if a woman is actually menopausal becomes incredibly urgent. If she is menopausal, she doesn't need the contraceptive protection anymore, and she can get off the drug to protect her skeleton.
Which means the clinician has to play detective. If she has no periods to guide them, they have to rely on blood chemistry.
You have to look at the labs.
Right. They have to decode the body's hidden signals by tracking a very specific chemical messenger follicle stimulating hormone, or FSH.
As we know, FSH is usually our most reliable messenger. During a woman's reproductive years, the brain and ovaries are in a constant feedback loop.
A very tightly regulated loop, yeah.
But during perimenopause, the ovaries start running out of functional follicles. They stop responding to the brain's signals and stop producing as much estrogen.
Right.
The brain doesn't get the message receive signal, so it yells louder, pumping out more and more FSH to force the ovaries to react.
Exactly. So in a standard clinical setting, for a woman who is not on hormonal contraception, an FSH blood test consistently showing levels above 30 IUL is a highly reliable indicator.
Okay, 30 is the magic number.
Yeah, 30 IUL means ovarian insufficiency has set in. The ovaries are slowing down and menopause is imminent or has already arrived.
But here's where it gets really interesting. Remember what we said about Depo-Provera being a high-dose progestin?
Yes.
The medical literature reveals a major twist. Depo-Provera doesn't just suppress ovulation and estrogen, it actually suppresses FSH levels too.
Yeah, it completely complicates things. The drug actively interferes with the very test we use to check if the drug is still needed.
That is wild.
The mechanism behind this is fascinating, really. The hypothalamus and pituitary gland in the brain monitor hormone levels to decide when to release FSH.
Okay.
Because Depo-Provera floods the system with a potent progestin, the brain is essentially tricked into thinking the body is in the luteal phase of the menstrual cycle, or even pregnant.
Oh, wow.
Yeah, and the brain's response to that artificial signal is to just dial down the production of FSH.
So let's look at what this means for a clinician holding a blood test result.
Yeah.
Let's say you have a 51-year-old patient on Depo-Provera.
Okay.
No periods.
Yeah.
You run an FSH test. If that test comes back high, like above that 30 IUL threshold, the clinician can confidently celebrate.
Absolutely, because the brain is yelling so loudly that even the high-dose progestin can't suppress the signal. The ovaries are genuinely failing.
But consider the alternative. The test comes back low, maybe 15 IUL.
Then the clinician is completely stuck. A low result does not mean the patient isn't in menopause.
Right.
It very likely means the depot injection is artificially forcing that FSH level down, masking the reality of what her ovaries are actually doing.
You get a lab value, and you literally do not know if it represents the truth of her biology or just an illusion created by the medication.
Exactly. It's a chemical mirage.
It's maddening, and it completely explains why historically doctors were so frustrated by this.
Yeah.
But modern clinical guidelines have developed a highly specific, precision-timed protocol to outsmart the drug.
Yes, they have.
Because if the medication actively fights the test, you have to find a moment when the drug is at its absolute weakest. Timing basically becomes the entire diagnostic strategy.
Right. The clinical workaround exploits the pharmacokinetics of the medication, specifically its half-life.
Okay, break that down for us.
We need to measure FSH when the drug's concentration in the bloodstream has dropped to its absolute lowest baseline, which is known as the trough. For Depo-Provera, that trough occurs on the exact day her next repeat injection is due.
Which is usually around day 90.
Exactly, day 90.
It's like waiting for the tide to go all the way out so you can finally see the rocks on the beach. You can't see the rocks when the water is high, when the drug's actively flooding the system.
That's a perfect analogy.
You have to wait for that tiny vulnerable window where the natural hormone signals can peek through the chemical blanket of the contraceptive.
And catching the body in that trough is the only way to get a clinically useful reading. But how we apply that reading depends heavily on the patient's age.
Right.
The guidelines outline very strict, concrete steps for discontinuation. Let's look at women under 50 first.
Yeah, if a patient is under 50, the guidelines across the board say do not test.
Period. Just don't do it.
Even if she hasn't had a period in 5 years on the drug.
Right. The clinical reasoning here is all about hormonal volatility. In younger women, perimenopause involves wild fluctuations.
It's just inherently unstable.
Exactly. The sources are very clear that isolated FSH levels in this age group are wildly misleading. You might test her as day 90, catch a spike in FSH, and declare her menopausal.
But then what happens?
Well, the ovaries can unexpectedly rally a month later, dropping a rogue egg. If you've taken her off the contraception based on that one test, she is entirely unprotected.
Oh, wow. So she could get pregnant.
Exactly. The recommendation is to simply endure the diagnostic blind spot and continue the contraception until she hits 50.
Okay, so she hits 50. She is at that crossroads where bone density concerns are really mounting. What actually happens in the clinic?
She comes in for her scheduled injection on day 90, and right before the shot is given, blood is drawn for an FSH test.
And here is where we see a fascinating divergence in medical philosophy between different regions.
Yes, we do.
The UK's Faculty of Sexual and Reproductive Health Care and the Australian guidelines take a very specific stance on the verdict. If that day 90 blood test comes back over 30 IUL, she cannot stop the contraception immediately.
Which I know feels counterintuitive to a lot of people.
It really does. You get the positive test showing her ovaries are failing. But the UK and Australian guidelines say she must continue using her contraception, or a non-hormonal alternative like condoms, for 1 additional year to be safe.
Right. They prioritize a behavioral safety net. Even with a high FSH reading at age 50, they acknowledge the slight statistical risk of a final unexpected ovulation.
Better safe than sorry.
Exactly. By mandating 1 final year of contraception, they completely eliminate the risk of an unintended pregnancy in a high-risk age bracket. It's an extremely cautious population-level approach to risk management.
But the North American Menopause Society guidelines offer a different perspective on this stakeout. They demand a bit more biochemical confirmation rather than just waiting a whole year.
Yeah, the North American approach focuses on proving persistent ovarian failure.
So how does their protocol work?
Well, under their guidelines, you do that first test at day 90. If it's over 30 IUL, you don't automatically trigger a 1-year waiting period. Instead, you administer the injection, wait another 90 days, and test her again right before the subsequent injection.
Okay, so 2 tests.
Right. If both tests, taken 90 days apart at the hormonal trough, are over 30 IUL, then menopause is definitively confirmed.
And then she can stop the method without the mandated 1-year wait.
Exactly.
It's a brilliant contrast in medical logic. The UK favors a time buffer, while North America demands replicated chemical proof to avoid keeping a woman in limbo for a full year if the first test was just a fluke spike.
It really shows how different medical bodies weigh risk.
But what if, on day 90, the test comes back low? Like under 30 IUL?
Then the tide didn't go out far enough, or the patient simply isn't in menopause yet.
Right.
She must continue her contraception, and the guidelines suggest repeating the entire stakeout process, waiting for that day 90 trough a full year later.
Wow. So what does this all mean? When we step back and look at this entire journey through the clinical literature, it means diagnosing menopause on the contraceptive injection requires a profound understanding of how age, bone metabolism, and suppressed hormones all interact.
It is deeply complex.
It's a calculated chemical stakeout demanding patience from both the doctor and the patient.
And I think this raises an important question about how we practice medicine today. You cannot apply a blanket one-size-fits-all rule to a transition this complex.
No, you really can't.
Navigating this requires looking at the patient's specific priorities. A clinician has to ask, is her primary goal protecting her bone health? Is it avoiding a return of heavy bleeding? Or is it simply the psychological peace of mind of knowing when her reproductive years have definitively ended?
It's not just about reading a lab value, it's about treating the person sitting in front of you,
Precisely.
which leaves us with one final lingering thought for you to mull over. We have spent this deep dive talking about precision tests, half-lives, and 90-day windows.
Lots of technical details, yeah.
But there is a broader medical consensus that by age 55, natural conception is so exceptionally rare that all women can safely stop contraception, regardless of their bleeding patterns or what any blood test says. Eventually, nature takes its course.
The biological clock always runs out in the end.
But think about the sheer power of this medication up until that point. We are talking about a simple shot every 3 months that can so thoroughly pause and mask our biological clocks that highly trained doctors have to play detective just to figure out what phase of life the body's actually in.
It's kind of incredible when you frame it like that.
We can turn off the headlights, we can silence the engine, but beneath all of that chemical intervention, the machinery of aging keeps moving in the dark. It makes you wonder, with all our scientific precision, how many other biological mysteries are still out there, just waiting for the tide to go out so we can finally see what's hidden underneath.
It's a testament to both human ingenuity and the enduring complexity of our own biology.
It really is. Until next time, keep diving deep.